Very good afternoon to all of you. Gives me great pleasure to be here. Thank the Andhra Pradesh Ophthalmic Society. I thank my friend Dr. Sujata for being here. It's heartening to see that there are at least 4 or 5 other than the speakers in the audience, because oculoplasty is catching up as it should. It's the bridge between of the eye and the body. So I bring you all greetings from my alma mater, Sarojini Devi Eye Hospital and Regional Eye Institute in Hyderabad. So my topic, I'm going to talk about thyroid eye disease. I know it's a much spoken topic, too many things to do, and I have another speaker who's going to speak on the very important side effect of thyroid orbitopathy, which they have to correct. So this picture is very interesting. That is the picture on the gate of St. John's, Cambridge, and it depicts a person. This is way back in 1516 and depicts a person with exophthalmos, which shows that thyroid orbitopathy was recognized even way back then. And even in 1040 to 1136, Zain al-Din Syed Ismail ibn Hussein, it's a very tough one to pronounce, in his treatise did mention about thyroid orbitopathy. So what are you seeing in all these pictures? What is common to all these pictures? It is the lid retraction, which is the commonest feature of thyroid orbitopathy. The dysthyroid neuropathy is the worst, but the commonest is the lid retraction, and therefore we need to see how we are going to treat it. I'm not going to talk about the Rundle's curve, about all the other features, the classifications and all. Going to concentrate on two things. One is the lid retraction, which is the commonest feature, and the second, which is not very often dealt with, the psychosocial impact of thyroid orbitopathy on the patient. So as we all know, upper lid retraction is the most common ocular feature of thyroid orbitopathy, and the mechanism for this is proposed that there is increased sympathetic stimulation or tone of the Muller's muscle, both in the upper and lower lid, because you have scleral show upper and lower. And as the disease progresses and becomes old, fibrosis sets in those muscles, which give a permanent lid retraction. The proptosis, which is present along with thyroid, also contributes, because the eyeball is pushed out, the eyelids are pushed back, which also causes lid retraction. Now there are various methods tried. As you all know, in the Rundle's curve, in the active phase, you can only use symptomatic therapy for the thyroid, no permanent surgical outcomes, unless of course thyroid optic neuropathy is threatening and there is no other way to treat it. So all the symptomatic or the temporary measures used were hyaluronic acid to weigh the lid down and bring it down so that there is no lid retraction, because lid retraction often causes a lot of undesirable side effects to the patient. Botulinum toxin also has been tried with variable success rates. Sometimes it is successful in some people and some people not. Cannot really predict in whom it is successful and whom it is not. Triamcinolone is the other old tried and tested therapy for injected into the levator muscle, and this is often useful. And my points are only going to be about triamcinolone, because we did a study and found a lot of wonderful results. So the definitive surgery, as we all know, has to be tried after the disease has died out, and various graded resections of the Muller's and LPS are available to us. Weight sometimes have been tried. So we recruited a total 26 eyes of 19 patients in our study, and the disease severity was graded based on CA score, and who had a CA score of more than 4 to 6, not the people who had very low CA score, were subjected to triamcinolone injection subconjunctivally. They were reviewed at 2 weeks, 1 month and 3 months. This is the procedure. You can see that we are using a insulin needle and we are going between the Muller's and the LPS. Now what we noticed, to our pleasant surprise, was that not only the lid retraction but also the lag, the exposure keratopathy, the extraocular muscle restriction and the proptosis surprisingly reduced extremely well at 3 months time after giving the subconjunctival triamcinolone injection. The CAS activity, of course, when the proptosis subsides, when the lid retraction subsides, exposure keratopathy is bound to go down. So these are a few pictures of the patients we had. You can see the lid retraction and you can see her picture after we have given the triamcinolone. There are 3 pictures here, 3 patients. So this into LPS and Muller's we found was a very effective treatment in resolving upper eyelid retraction due to thyroid, and it worked best in people who were not having a TED of more than 12 months duration. Now the second aspect which I mentioned and I wanted to say is the psychosocial aspect. So this patient started our thinking and going into this. She was a school teacher. She had only lid retraction. CA score was quite low in her, and because of the lid retraction she was having problems, and that is what she told us, that she cannot go to school, cannot continue her job and other things. So therefore, searching history, we found that many of these people were thought to be psychologically affected. If you see what I have underlined in red, this is Parry, Caleb Parry has written a treatise about what patient he saw in 1786. After delivery, we know thyroid changes suddenly after after the onset of menarche, delivery, menopause, the thyroid hormones change, and what they saw was that the patient exhibited an appearance of agitation and distress, especially on any muscular exertion. So that tells us that there was a psychosocial element which was recognized even then. Robert Graves also mentioned that a lady became affected with symptoms which are supposed to be hysterical. So again, patients with thyroid related orbitopathy were thought to have some kind of a psychosocial illness. The constant watering, the dryness of the eye induces the patient to have lot of rubbing, feels a sense of isolation because they do not look normal and they themselves are very conscious. Vision is blurred, which affects many people's profession, which requires clear vision. So quality of life studies have shown that thyroid eye disease may have more significant lifestyle consequences than chronic lung disease or diabetes mellitus. And we did a study to analyze the correlation between the clinical grading of the systems used with the patient's perception of psychosocial limitations or isolation and other things. And we used a questionnaire where we used questions about visual limitations during driving, the profession, what they do, household chores, depending on the category of the patient. Psychosocial limitations, where the patient was not able to go and mingle with people in functions and other things. And then we also asked a question that whether educating them about their disease helped them to overcome their sadness about what they had. So when we plotted a scatter plot, we saw that though the CAS activity was not much, the psychosocial limitation was much more. Same with UGOGO and with Visa also. So we found that the psychosocial impact did not always correlate with the severe CAS scores. People with just lid retraction, people with a change in their appearance did perceive the severity of the disease in their mind, not graded by us as a CAS score. But counseling did help them, and therefore we feel that this requires to be addressed and included in the classification. I always like to end with these lines of Sir Duke Elder, which I feel hold good today. I am going to read out from Sir Duke Elder. Thyroid related orbitopathy is a very common condition which leads to disastrous consequences. The cause of which is unknown, we know a little bit today. The pathology obscure, and the therapy is somewhat ineffective, and is certainly no cause for congratulation. Thank you so much.